Hello, good morning, good afternoon, and very good evening, everybody. My name is Syed Azhar. I'm a social worker and one of the directors, ISSUP Pakistan chapter. I'm also working as executive director, New Life Rehab Center, Rawalakot, and today I'm going to serve you as moderator for this webinar. And on behalf of ISSUP Pakistan chapter, I would like to welcome you all for joining us and to attend this webinar on a very important and interesting topic, new psychoactive substances. Particularly, we will talk about designer benzodiazepines to learn about the concepts of misuse, abuse, and dependence associated with benzodiazepines. Use of benzodiazepine in the treatment of substance use disorder, clinical and adverse effects of illicit benzodiazepines. This webinar will explore benzodiazepine, the mechanism of action on brain, abuse and dependence. It will also discuss the new surge in abuse of designer benzodiazepine from a Pakistan's perspective. This session will also conclude by highlighting the treatment and management of disorders related to designer benzodiazepines use. As many of you know that we as National Chapter ISSUP Pakistan conducting this webinar with the support of our parental organization ISSUP. So I would like to share a brief introduction of ISSUP quickly. Like ISSUP is an international membership organization with, with over 30,000 members from all across the world, including Latin America, Africa, Europe, Asia, and Middle East. And there are around 30 national chapters also has been established under the umbrella of ISSUP Global. And ISSUP Pakistan chapter is one of those. And there are many national chapters are in progress to become a member of ISSUP family. The main objective of ISSUP is to connect professionals through networking, knowledge exchange, and training, sharing the very best in evidence-based ethical approaches and promoting equality in all areas of prevention, treatment, and recovery care practice. And if you know more about ISSUP, you can visit ISSUP website, which is www.issup.net, where you will find information how to sign up for free membership if you are not member yet. The website also has a wealth of resources and publications for you to learn and apply for in your professional development as well. And before we introduce our guest speaker and start presentation, I would like to share a few guidelines for all of you. Like as usual, you all have been muted to avoid background noises because sometimes it may distract you from learning to the webinar. But if you want to share any feedback or want to ask any question regarding the topic, please use the chat box. And after the presentation, we have a Q&A session, and we will try all our best to answer your questions within the limited time. Now I would like to introduce our very honorable and committed guest speaker, Dr. Syed Azhar Kazmi. He is consultant psychiatrist, associate professor and head department of psychiatry, Poonch Medical College, Combined Military Hospital, Rawalakot. He is the chapter chief, Pakistan Psychiatric Society, Azhar Jammu and Kashmir, and member, Executive Committee, ISSUP Pakistan chapter. Thank you, sir. Hello, sir, and thank you for your precious time to join us and welcome you on behalf of ISSUP Pakistan chapter. We formally welcome you, and floor is yours to share your presentation, and we'll see you after the presentation to have a Q&A session. Thank you, sir.
Thank you very much, Saima, and thank you very much, ISSUP Pakistan chapter and ISSUP International for giving me the opportunity to talk about this very important topic, that is designer benzodiazepine. So this is a disclaimer from the ISSUP. Philosophically speaking, a short-lived player is the parent of pain. This is the philosophy, not the science. But when we see that short-lived pleasure is always related to dopamine, short-lived pleasure is a hedonistic type of living a life, and most of the time it leads to trauma, most of the time it leads to pain, and most of the time it leads to difficulties. Today we are going to discuss the history of benzodiazepine. Today we are going to discuss that what are the designer drugs and what are the designer benzodiazepines, their mechanism of actions, and the psychodynamic concept of drug of choice, and why the human brain want newer and newer illicit drug. With this, also, we will discuss the prevalence, the hazardous effects of this designer benzodiazepine, and treatment and management of designer benzodiazepine dependence or abuse. Let us start with the history of benzodiazepines. That before benzodiazepines, before 1950, we have barbiturates, and barbiturates are used for sedations. Barbiturates are used as anticonvulsants. But then comes the benzodiazepines. The first one was chlordiazepoxide, and it is actually the central nervous system depressant. It has effect on the GABA, that is the gamma aminobutyric acid inhibitory neurotransmitter in the brain, and it has sedative effect. It is the muscle relaxant, and it has also anticonvulsant properties. So the barbiturates, they were replaced by this benzodiazepine in 1951. And as I said, that chlordiazepoxide was the first one. And as all of the mental health professionals, they are well aware of the fact that chlordiazepoxide is still the drug of choice in treating alcohol withdrawal. Diazepam uh, was approved in 1963, and from 1963, from late 50s to 1977, these benzodiazepine became the most prescribed medication in the world. So you can see from this fact that they such weapon was made by human, that uh, it was so soothing, so relaxing, and so effective for the patient that in within 15 years, these medication became the most prescribed medication in the whole world. What are the designer drugs? Most of you are well aware of this term, the designer drug, but some of you who are not well aware of the term, uh, this designer this term was coined in 1985 when the ecstasy, MDMA, it gained popularity, uh, specifically in America and in the West. And designer drug is actually the structural or functional analog of a controlled substance, and that has been designed to have the same pharmacological effect as that of original drug. So it has some added advantage over that drug, that it has enhanced pleasure, and it is not detectable through standard drug test like urine test or blood test that we regularly use in our clinics or in our setups. It is detectable only through highly, highly specific radioimmunoassays. Now coming to the different type of designer benzodiazepines, and among all of them, some are listed here, and their small description and their effects are listed here. Adinazolam. Adinazolam is one of the most sedating uh, designer benzodiazepine, and it is actually the functional analog of alprazolam. And for its effect, most sedating effect, because it has most sedating effect, it is used. It can be used as a rape drug, and it can be used as a sedative. And the second one is bromazepam, and it is also the analog of alprazolam, and the other one is clonazepam and diclazepam. Diclazepam is actually the analog. Analog means having the same effect as the uh, original drug, which is pharmacologically used. And diclazepam is actually the analog of diazepam. Flualprazolam is derivative of alprazolam. And now this is a very interesting designer benzodiazepine, that is flubromazolam. Flubromazolam is highly potent, it is highly sedative, and it is highly lethal drug. And you can see from the slide that this drug is lethal in doses up to 3 milligram only. So this designer benzodiazepine is one of the most dangerous type of designer benzodiazepine available uh, in the market. And desalkyl fluorazepam, and this is another analog of diazepam. And nimatazepam, this drug is legal in Japan and some other countries like Malaysia and Indonesia, but in other countries it is used, it is illegal and used as a designer drug. Nitra, nitrazolam, pyrazolam. These two are similar to, are analog to bromazepam that we used in our clinics. And another drug is RO54864. This is the drug, designer drug, made in the laboratory, and analog of diazepam, highly sedative, have anxiolytic effect. No, have anxiogenic effect. It can produce anxiety, and it can lead to the panic attack, and it can also lead to the convulsion or seizures. So this effect is very different from other benzodiazepines and other designer benzodiazepine. This effect of RO54864. Flubrotazolone and 1,4-butanediol. 1,4-butanediol is actually known as the liquid ecstasy, and it is actually the analog of gamma hydroxybutyrate. And you are all well aware of the fact that gamma hydroxybutyrate is a depressant, and it's also known as the rape drug. And the street name of 1,4-butanediol is 1,4. And another analog of GABA is the drug, designer drug known as the tolibut. So these all designer drugs, they are similar in structure, to the benzodiazepine that are available, but they are different functionally because they have enhanced effect on the CNS, on the central nervous system, and they have the enhanced effect on the dopamine circuits of the brain, and they have the increased potential of dependence in the human brain. We will now see the mechanism of action of these drugs. And as you all know that analog means similar. So the designer drugs, designer benzodiazepine, they have the similar mechanism of action as benzodiazepine, but in enhanced way. Benzodiazepine are positive modulators of GABA A receptors, and as you all are aware of the fact that gamma amino butyric acid receptors, and these are actually the inhibitory neurotransmitter receptors. They are present throughout the nervous system, and their main function is to inhibit and to depress the central nervous system. And benzodiazepine actually increases the affinity of these receptors, and by depressing the CNS, benzodiazepine leads to relaxation, and it also has the that's why it also has the anxiolytic effect that we see with these benzodiazepine, and same is true with the designer benzodiazepine. So this is the positive effect that we observe from these benzodiazepines, and what how they cause addiction, and by firing dopamine in the ventral tegmental area of the brain. So the brain wants more and more dopamine, and the brain wants the patient to take more benzodiazepine to stimulate this VTA, that is ventral tegmental area, and it leads to the repeated abuse, and it leads to addiction. As you all are well aware of the fact that what is the difference between abuse and dependence syndrome, according to the DSM-5, and same is true with the ICD-11, that is International Classification of Diseases given by the WHO, that there are some certain points related to the dependence syndrome. And the number one is taking the substance in larger amounts or for a longer period of time, and developing tolerance. Tolerance means that first the person takes it in a very minute or in a very small amount, then the brain needs more amount to get the similar effect, so it leads to tolerance. And with that, withdrawal symptoms when a drug is not there, and it leads to anxiety, it leads to insomnia, and irritability and agitation, that is decreased threshold for anger, spending a lot of time in getting, using, or recovering from use of substance. And so this leads to the decreased functionality in all the domains of life, that is self-care, care to others, in occupation, or in social care. As mentioned, loss of functionality, and loss of functionality means the loss of functionality in most of the domains of life. And the person who is using the drug is well aware of these hazardous and harmful effects, but he continues using the drug because the dopamine circuit the demand of dopamine circuit is so strong that he can't quit it despite knowing that it's harmful, giving up all the recreational and social activities. So this is related to the dependence syndrome, uh, and this is described by the DSM-5 and also by ICD-11. As a country in which there is a lot of opium, and opium comes from our neighborhood, Afghanistan, and our 8 million people, they are suffering from opium dependence, and our 4.5 million people, they are cannabis dependent in Pakistan. We usually think that designer drugs, this is not our problem. This is the problem of the West, but it's not true. The fact is that designer drug is in Pakistan, and there is a surge after COVID-19, and there is a new surge. There is an expected new surge after this economy crisis in the country of these drugs. And it is obvious, this is the Gulf News, and it was published in 2019, that Pakistan to introduce new laws to crack down on the synthetic or designer drugs. So there is a law, now there is a law about these drugs, and these drugs are available in Pakistan through different links through dark web. Although there is no clear-cut prevalence study, and there is no publishing data that is available for the prevalence of the designer drug, and specifically for the prevalence of designer benzodiazepine in Pakistan. But the fact is that these designer drugs, these are available in Pakistan now. Talking about the world, and as you can see from the slide that uh, according to UNODC drug report to 2022, 3.9 to 4% people of USA, they use designer drug. This is not specific about designer benzodiazepine, and 2 to 3% of worldwide people, they use designer drugs, and this is written in the textbook of addiction psychiatry. And we all are well aware of the pandemic effect, the post-COVID effect, and there is a surge in the use of the links, web links, and the dark web for purchasing and trafficking of these designer drugs all over the world. And world is under this economic crisis, and we expect the surge of the drug abuse as a maladaptive coping strategy all over the world. This is a psychodynamic concept, and very important and very interesting concept that is of drug of choice. We are not uh, talking about drug of choice pharmacologically. We are talking about drug of choice by personality. It means that specific personality traits that lead towards a specific towards inclination towards a specific drug, and like, for example, a person who has suffered a psychotrauma is inclined towards a pain killing anti pain killing drug that is opioid. And painkilling means the killing for the brain. The person's low self-esteem always, his personality needs stimulants. And the person who has anxiety and neurotic traits uh, is inclined uh, towards the use of depressant to satisfy or calm his neurotic and anxiety traits. So this concept is very important because in the treatment plan you can incorporate as a addiction professional these things like uh, when a person he or she is dependent on depressant or benzodiazepine or designer benzodiazepine. So one must evaluate the anxiety and neurotic traits in himself or herself and must care of those anxieties and neurotic traits and the intracyclic conflicts inside the brain. So it really helps in recovery and treatment. So why people they use newer and newer uh, drugs and newer um, uh, what can you say these designer drugs. Here in this slide you can see the three highest peaks of Himalaya range. Starting from the right, on the right you can see Rakaposhi. In the middle there is the beautiful Naga Parbat, and on the left of the slide you can see the K2. So positive way and adaptive way to use hedonism and pleasure seeking trait. Hedonism is actually the pleasure seeking trait inside a personality. And positive way or adaptive way to satisfy this hedonism is to conquer or climb Rakaposhi and then climb the Nanga Parbat and then look for the K2 and then for the Mount Everest. So the journey continues from one mountain to another, and for a climber to satisfy the hedonism in a very, very adaptive way. But what is the maladaptive way? It is a never ending hedonism from one drug to another, starting from alcohol, then going to benzodiazepine, and then experiencing designer benzodiazepine, and then combining fentanyl with some designer benzodiazepine. So this is the never-ending hedonism, and it's a human nature. But being adaptive or maladaptive is choice is optional, and choice is optional for every human brain. So he can be adaptive in very positive way, like explained through the example of a climber, or he can be maladaptive by using one drug and then another and then another. So this never-ending hedonism, it has led the humanity towards the discovery and invention of newer and newer drugs. And as you are all aware of that, in the market, you see every day you see a newer drug with a newer mechanism, designer drug with a newer mechanism coming in the market. And it is actually the never-ending hedonism behind this phenomenon. All are well aware of the fact that these designer benzodiazepine are hazardous and hazardous to the physical and mental and social well-being, and their hazardous effects are dependence, as we have discussed, amnesia. Uh, Amnesia is actually the hazardous effect of every depressant, including alcohol. In alcohol, you see the patients with Korsakoff psychosis, with Wernicke's encephalopathy, and in benzodiazepine and designer benzodiazepine, amnesia, both of short term and long term, is very common. Tremors, intention tremors in the patients. This is a common side effect and the common hazardous effect of benzodiazepine dependence. Insomnia, because the GABA receptors and they become dependent on these benzodiazepines. So when the drug is not available, it leads to the hyper excitability and it leads to insomnia, decreased cognitive ability, and especially decrease in attention and concentration. And psychomotor impairment is also there, and these two, decreased attention concentration and psychomotor impairment, can lead to road traffic accidents. And road traffic accidents are very common in patients suffering from benzodiazepine dependence and suffering from designer benzodiazepine use. Uh, this is a study published in American Journal of Public Health in 2016 that benzodiazepines are second most common drugs linked with overdose deaths in USA after opiates. So you can see from this fact that benzodiazepine, they are also lethal drugs. In patients with EUPD or borderline personality, with the use of benzodiazepine, you can observe more impulsive behavior in those patients and decrease metacognition and self-regulation. Metacognition means thinking about the thoughts and analyzing about self and analyzing about the thoughts. So from this fact, you can analyze that benzodiazepine can affect the personality development also. Normally, 1 to 1, 1 plus 1 is equal to 2, but here 1 plus 1 is equal to 11. That is the synergism, the increased, enhanced effect of two drugs. When benzodiazepine is designer benzodiazepine is mixed, is taken with another designer opioid, fentanyl, it is a lethal combination. These both drugs have a synergistic effect on CNS, and it can lead to convulsion, coma, and death of a patient. Same is true when someone take benzodiazepine or designer benzodiazepine with alcohol or with other opiates. So this synergistic effect can be observed with the use of these two drugs in combination. Another concept about comorbidity is adding insult to already present injury. If one if someone is suffering from a psychiatric illness and he or she starts using this designer drug, then it's just like adding insult to already present injury. So what are the comorbids of benzodiazepines and designer benzodiazepines. These are anxiety and stress related disorders. These are the phobias and panic attacks and panic disorders, depressive illness, personality disorders that we have already discussed about, emotionally unstable personality, and other substance use disorder are use of other depressants, use of opiates. Gaming and gambling disorder is also uh, associated and comorbid of this designer drug abuse or dependence. Now, coming to the management, prevention is always better than cure, and we should focus as mental health professionals, as addiction professionals. We should focus on the prevention of these uh, abuse, and prevention means by giving the psychoeducation to the community and to the masses, by giving by indulging in the educational campaigns, in the drug awareness campaigns about these designer drugs. We can prevent the use of these drugs. And when the patient start using this drug, and when the patient get dependent on these drugs, the motivational interviewing is the first way to not only to enhance motivation, but also to know about the level of motivation, as you all know as addiction professionals. The important thing about benzodiazepines is that the withdrawal of these drugs can last for 3 to 6 months. And normally we see that withdrawal of heroin, withdrawal of methamphetamine, they are for a few weeks. But from treatment point of view, it becomes very difficult if withdrawal is so long. So it lasts for 3 to 6 months, and this is a valid reference, that is Maudsley prescribing guidelines. So how we treat these benzodiazepine dependence, or the designer benzodiazepine dependence? First, we will change the designer drug to a long-acting benzodiazepine, like we will change into bromazepam, lorazepam, or diazepam, and then reduce the dose 1/8 after every 15 days, and taper off very gradually. And uh, with that, we will also take care of the insomnia, the agitation that patient is suffering from, the depression, anxiety, and if there is any phobia, we will also take care of it. So by managing all these symptoms, pharmacology, only we can then manage benzodiazepine dependence. So with all this, we should also take in mind the comorbids that patient is suffering from, and there should also be social and family support for the patient. What is the treatment of choice for insomnia? Obviously, the first treatment should be the non-pharmacological and sleep hygiene. And apart from benzodiazepines, we can also give low dose of quetiapine, that 12.5 milligram of quetiapine, or 25 to up to 50 milligram of quetiapine we can use for insomnia, and low dose of trazodone, which is an antidepressant. For agitation, we can go for SSRIs, breathing exercise, and beta blockers. And one thing to note here, that equivalent doses should be used in patients when tapering the benzodiazepines and when starting the long-acting benzodiazepines. So another last thing to note here is that as you all are well aware of the fact that addiction treatment is just like holding sand in your fist, in your clenched fist, and if you hold it tight, it will spill out of your hand, and if you hold it lightly, then it will also it will not remain in your hand. So it means that you have to find a balance. You have to be very professional. You have to master your skills to deal with the patient suffering from addiction. The path is so long and the path is so difficult, but it's not impossible, and destiny is achievable. And thank you very much for your passionate listening. Now the forum is open for any sort of question. Over to you, Simon.
Okay, all right. Thank you very much. First of all, I'm really appreciate the to have a wonderful presentation from your side, and thank you for your precious time once again. So now we have a Q&A session. So we are just going to have few questions, as we have been received a lot of questions, but we will have some questions from the audience. The first question we received from the audience that they are asking, what are the common side effects of benzodiazepines?
We have already discussed the hazardous effects of benzodiazepine, but commonly they cause sedation, and they cause amnesia, or the decrease the memory issues, and they affect both short-term and long-term memory, and they cause problem in psychomotor abilities, and they cause problem in the cognitive abilities related to attention and concentration of the brain, and so they can also lead to insomnia. So these are all the common side effect that we see in benzodiazepines.
Thank you very much, sir. Thank you to answer our question. So we have a next question that which one is the safest use of benzodiazepine?
Actually, as in one slide, we have seen that in 1977, benzodiazepine became one of the most prescribed drug all over the world. And when we normally see the prescriptions in our setting in Pakistan, and not only in Pakistan, in West also, benzodiazepine, they are still used, and but the safe first is safe indication. Benzodiazepine are used in psychiatry in different disorders, like to take care of the agitation and aggression of the patient, like in phobias, in insomnia, and also in depression and anxiety. But the safe point here is one should prescribe this medication only for 3 to 4 weeks, not more than 3 to 4 weeks. So when this medication is prescribed in an appropriate dose for a short period of time, it's one of the most effective medicine, our most effective weapon that we have, as a physician.
Thank you very much, sir. And we have a next question that what brain region are affected by the use of benzodiazepine, and what would be its effects on one's daily functioning?
Okay, as we have already discussed that the GABA neurons, the gamma aminobutyric acid A receptors, they are found all over the CNS system. So these benzodiazepine, they have a strong affinity for those neurons, and GABA is actually an inhibitory neuron. So it means that whole brain is affected by this benzodiazepine, and specifically uh, the ventral tegmental area, that area which which can lead to the firing of increased dopamine, and which leads to addiction, is also affected. So it means that one, the whole brain, and second is the VTA. These two areas are the most affected by the benzodiazepine. And the second part of the question is that how it affects the daily life of uh,
Yes, sir. Functioning of daily life.
by affecting the memory, by affecting the cognitive abilities, by affecting the attention and concentration, by affecting the psychomotor abilities of a person, and by affecting by having the intentional tremors of the hands, so it can affect the daily functioning. And apart from this, when a person get dependent on benzodiazepine, his overall functionality, including self-care and including care to other, including occupational care, it these all domains of life, they become disturbed.
All right, sir. Thank you very much. And the next question we have been received from audience that as you have been shared in your presentation, the perspective of Pakistan regarding the use of benzodiazepine. So they are asking that how much Pakistani population got addicted or even used two of it, like benzodiazepines?
There are no specific studies about the use of designer drugs and designer benzodiazepines in Pakistan, and we are lagging behind in research, as we all know. But some of the stats that is coming in my mind is uh, the 40% of prescription given by the different specialists, including surgeons, cardiologists, uh, neurosurgeons, neurologists, nephrologists, and cardiologists, and psychiatrists. They all have one type of benzodiazepine in it. So people here, they use lot of benzodiazepine, and as I have mentioned, 40% of prescriptions, they have benzodiazepine written on it without the limitation that for how long the patient is advised to take it. So patients are using it for months and for years, and getting dependent on these benzodiazepine. This is the one study that I have in mind related to Pakistan.
Thank you, sir. Thank you very much once again. And can you please share, this is actually a question from one of our audience, that which countries are using the most benzodiazepines? Could you please share? Yes.
Uh, which country is using? Actually, those countries which don't have a regulatory authority, and those countries where the regulatory authority are not very functional, and where the law enforcements are not very good, uh, and benzodiazepines are easily available on pharmacies, and people they can get it without prescription. So there these benzodiazepines use are very common among the people, because without prescription they can get these drugs from pharmacies, and among those countries are mostly low and middle income countries, including Pakistan.
Thank you very much, sir. Wonderful answer. Just having last but not the least question. How can we guide a layman about its dependency? I mean, the benzodiazepines.
So as a psychiatrist, as a mental health professional, um, we must educate the people about the use of these benzodiazepine, and the addiction potential that they have, and we must educate them about the availability of designer drugs on the web. And this is the first and most important thing that as a psychiatrist we should do. The second thing is that whenever we prescribe benzodiazepine to a patient, we must write the amount of the tablets and the period for which we are going to advise, like for 2 weeks or 3 weeks on the paper. And we must tell our colleagues to do so and to practice like this. So these benzodiazepine and these depressants, the people they can't get it easily from the pharmacies, and they can't get dependent on it. So these two are the most important things that as a physician we can do easily.
Thank you very much. Thank you for excellently answering our question. So as I said, we have a time to take one more question. If you allow, then we can have another question.
Yes.
So we have received another question, that what are the long-term effects for someone who has used for a long time?
Uh, Please repeat it again.
What are the long-term effects for someone who has used for a long time?
Long-term effects of benzodiazepine.
Yes.
Okay, we have already discussed it, and well, the long-term, the most important effect is on the memory, and many amnestic syndromes. These are related with the use of these benzodiazepines, and dependence syndrome is a long-term effect of use of benzodiazepine. The rebound insomnia, and never take insomnia lightly. Sleep is a very important human brain function, and as per calculation, human one-third of human life uh, uh, is uh, about sleep, and because we sleep normally 8 to 10 hours, so insomnia leads to the mental exhaustion. Insomnia leads to decreased immunity. Insomnia leads to the physical exhaustion. So it is also the long-term effect. Another long-term effect related to this benzodiazepine, that benzodiazepine shortly in a short term is itself anxiolytic, but in a long term it's anxiogenic. It causes anxiety and it causes depression. And benzodiazepine in a long term can also lead to the lethal effects like suicide.
Thank you very much. Thank you, sir. Once again, first of all, we had a wonderful presentation from your side, and we had a excellently answer from our question received from our audience as well. And so on behalf of ISSUP Pakistan, I would like to say thank you very much once again for your precious time and providing us opportunity to learn from this very important topic. So once again, if you would like to share a few comments from your side, then
Thank you very much, Saima and ISSUP Pakistan for giving me the opportunity to talk about this topic. And we need
sir, would you like to
more
share a
to
few
know.
comments, sir?
Yes.
I was asking that would you like to share anything for or any message for our audience? You can share. Then
Yes.
we will close this session. Thank you.
Yes, yes. I have a message and I have a comment that first of all, thank you very much and for inviting me to deliver this presentation. And as we all of know that all of us know that the drug abuse, drug dependence is now a pandemic like COVID-19 for whole world. And we have to develop our professional skills, and we have to develop and enhance our knowledge as a psychiatrist, as a mental health professional, and as an addiction professionals to cope and to counter this pandemic all over the world. Thank you very much again.
Thank you very much, sir, once again. And on behalf of ISSUP Pakistan chapter and ISSUP Global, I would like to thank all our audience and for sharing your valued feedback, which really help us to improve our work, and your appreciation and your appreciation also help and motivate us to continue our efforts. And on behalf of ISSUP Pakistan chapter, I would also like to thank all ISSUP's executives leading team for providing us this wonderful platform to learn and share from each other. And I particularly share my special thanks to Ma'am Joanna, Miss Livia, Miss Ola, Mr. Jeff, Mr. James, and Miss Olivia for providing us all moral, technical, and scientific support to take new initiatives and to conduct such events and make this event possible. Thank you once again. Take care. And I would also like to share that the recording of this webinar is also available on ISSUP website. So after closing this webinar or few minutes later, you can visit ISSUP website and ISSUP YouTube channel to watch this webinar again. If you may missed any part of this webinar, so you can click over there and watch this webinar and share with your friends and other members of professionals groups as well. So thank you very much once again for joining us. Hope to see you with another topic and with new webinar. Thank you, Dr. Azhar, for your precious time. Thank you, Ms. Olivia, for your support.